Sorry about being late again, but it is the GI block. Sorry? Sorry, what's happening?
في صوت buzzy noise. We should do it like this.
Okay, whatever. All right, so let's talk about the stomach. Let's start with acute gastritis. Now, you will see that the lesion that we will be talking about are going to become deeper and larger as we go through this lecture. So, starting with acute gastritis. In this one, you will see that there is actually, if you look at the mucosa that is affected with acute gastritis, you will see that if it does not have the petechial hemorrhage, it will be very hard really to tell. The reason for this is that it is extremely small, about 1 millimeter in diameter, 1-2 millimeter in diameter, and also very shallow. So without the hemorrhage, you will not be able really to appreciate it unless you look from the side. That's when you will start to see that there is, slightly missing or eroded, quote unquote, part of the mucosa in that region. So it is a transient, self-limited, where you find actually focal necrosis of the mucosa. And what is the cause? With acute gastritis, and really with a lot of the conditions that you will see that are associated with inflammation of the stomach. In the stomach, you don't need anything actually to create, inflammation, except the acid itself, by going back into the gastric wall. As you know, there are actually some defense mechanisms that prevent this. When these defense mechanisms break down, that's going to result in the retrograde flow of acid into the gastric wall, resulting in inflammation, necrosis, and destruction of that tissue. So loss of the gastric defenses. Now, how does that come to happen? For example, if it is related to the NSAIDs, we know that the NSAIDs are going to prevent the production of the prostaglandins, and prostaglandins have vasodilatory effect. So when there is vasoconstriction, the stomach wall is going to lose its very robust ability of rerouting the acid from the inside to other areas within the gastric lumen. So the fact that it's going to be lacking actually this vascular very profuse, very robust vascular network is going to be one of the reasons why there is gastritis with the NSAIDs. Now, the other reason for this is that it's going to block the production of bicarbonate. And as you know, bicarbonate, which is produced by the foveolar cells, the same cells that produce the mucus, is important because it's going to try to alkalize actually the secretions of the acids. So both ways. Now you will see that among this list, there are those that are going to affect directly the cell itself, cytotoxic. Example of that, the alcohol, alcohol abuse, and what will it do, on the foveolar cells. The same with cigarette smoking, but also with cigarette smoking, you add a vasoconstriction effect. So pretty much the whole thing, may be related to the, interruption of the vascular network, and also, creating weakness within the gastric wall. For example, if an infection is there, of course, that's going to add more, insult to injury. So infection with salmonellosis, may result actually in, increased permeability of the gastric wall to acid. That's going to result eventually in destruction of those cells. Also with any inflammation, whether it is from an infection such as salmonellosis or mechanical trauma. Every time you irritate or you damage or you traumatize a tissue, inflammation is going to follow suit. So as a result of that, you will see the neutrophils are going to be brought to the site of action, and they will start to actually, take out some of that tissue. So here are actually the defense mechanism that I hope you have covered with the physiology lecture. So you will see the surface mucus that is going to contain also the bicarbonate produced by the foveolar cells. And then the very rich mucosal blood supply, as I mentioned to you, it will work to rear out the acid that may have actually seeped through the gastric wall. And finally, the epithelial regenerative capacity. So anything that is going to affect that is going to be resulting in damage to the gastric wall. Now, in terms of, what do you call it? Let's talk about that from now. If it's only actually, resulting in, if it's only resulting in loss of the very, top layer of the gastric mucosa, that's going to result actually in what you call erosion, as we will see in a second. Now, if this is going to actually be deeper than this, once the process goes deeper into, the muscularis mucosa and into the submucosa, that's what you call actually a real ulcer. So the ulcer has to dig deeper than the rest of these entities. When it reaches the submucosa and, go through the muscularis mucosa, which is this layer here, and the submucosa, then you would know that it is actually a true ulcer. Now, the true ulcer has features that, the other entities will not have. For example, the true ulcer, there will be, some kind of fibrosis because of the chronicity of the process, in the underlying tissue right here in the bed of the ulcer, and also, some thickening of the blood vessels that are nearby. In addition to this, you will see that, the ulcer itself is going to be actually is going to have some tissue debris, especially when it is related to a benign ulcer. Tissue debris that is going to be the result of the work of the acid that has, gone through the gastric wall and destroyed this tissue right here in the pit in the bottom of the ulcer, as opposed to what you see in the rest of the entities that we'll talk about. In addition to this, you will see that the ulcer is going to have a much deeper, as you can see, and a much larger, usually up to 4 centimeter in maximum diameter. That's actually the benign ulcer. Anything beyond that, you should be suspicious of a gastric cancer that has ulcerated. All right, so. What else? You will see also when it comes to the acute entities as opposed to the chronic ones. Um, you will see that the border are very clear cut when it comes to the acute entities, and not as much when it comes to the chronic ulceration. All right, so how does it present? It may actually be completely asymptomatic, that will go unnoticed, or it may, be associated with bleeding, occasionally with hematemesis. And there is some epigastric pain, nausea and vomiting, one of the major causes of hematemesis. And it is superficial, as I mentioned to you, pretty small and pretty shallow, up to 1 centimeter in diameter. Here is what you have here. So if you look at this, without the hemorrhage, it's going to be very hard actually to tell it apart, from a normal really mucosa. But here with the hemorrhage and the pits that you see around, you're going to find that you're going to be calling it exactly what it is really. So you will look at this tissue and you will see that there are erosion, and the best way to find out is when you hold it on the side. Erosion, because you will see, some, pits, small, very small and shallow pits, that are present in the gastric wall, and you will see that in addition to this, hemorrhage. So it is erosion or erosive. That's one. Two, there is hemorrhagic. So this is why you call it acute, erosion hemorrhagic gastritis. Now, why it is gastritis? Because when you take a microscopic section and you look at it, you will see the presence of neutrophils that are in direct continuity. Some of them are within the gastric glands itself, as you can see here. There are some inflammatory cells within the gastric gland. In the GI, wherever you are in the GI, you may see actually plasma cells and lymphocytes. That's normal when they are in moderate number. Usually they are in small numbers, what you call a standby inflammatory infiltrate for any kind of injury that happens to that site. Now, the minute that you start to see neutrophils, in the lamina propria and in the basement membrane, that tells you this is very abnormal and that's an inflammation, and you need to work out the cause of that inflammation, as you can see here. So again, hemorrhage, erosion, and itis and inflammation. So it is acute erosive hemorrhagic gastritis. Now, the second one is going to be acute peptic ulceration. The other name for it is stress ulcers. In this case, you will see it usually in patients, who are in actually dire straits, meaning they are coming in with trauma, multi trauma, after MVAs, after motor vehicle accident, for example, or patients in the ICU who have been there for a while. So the end result is going to be that those patients are going to have so much acid that is going to be released into the body, that's going to overwhelm the local defenses that you see in the stomach. So some of them are related to severe burns or severe trauma, such as what you call the Curling's ulcer. The other ones is intracranial nerve injury. Now, the intracranial nerve injury are going to result in the stimulation of the vagal nuclei and the dumping of acid in the stomach. That again is going to overwhelm the local defense mechanisms of the stomach. So as you can see, it's a tight balance really between the defense mechanisms and the acid that is present there. Anything that is going to to interfere in this tight balance may actually tip the balance in favor of more acid that will overwhelm the defense mechanisms of the mucosal wall that we have just talked about a minute ago, and that's going to result in this acid going into the stomach and resulting in ulceration. All right, so usually they are multiple, they are small, slightly larger than the acute gastritis, and actually slightly also deeper than the acute gastritis. And one very important feature is that they are sharply demarcated from the rest of the tissue. There is no scarring or fibrosis nearby, as I mentioned to you, to actually compare and contrast them with the chronic ulcer. And the healing is going to occur with re-epithelialization, and that's going to happen over days or weeks after the insult. What are the causes of this? If you are in the stomach and you say actually two things, either NSAIDs or H. pylori, you're going to be right. So again here it is NSAID, as I mentioned to you, blocking the prostaglandin synthesis and also the secretion of the bicarbonate. The intracranial injury, it is directly related to the direct stimulation of the vagal nuclei and hypersecretion of acid. And then there is also systemic acidosis with all the tissue that are going to be destroyed in the process, whether it is actually trauma or whether it is someone who has been there in the ICU for a long time. You will see that in those patients, there's systemic acidosis that will be added to the acid that is in the stomach that will overwhelm the local defenses. Here are examples of the stress ulcers, as you can see. Multiple, small, round, very sharply demarcated. There is no fibrosis in the vicinity of these ulcers. There is no, and you can tell that it is very clear cut. What you call cookie cutter. The minute you are going through this, all of a sudden you see this. There is no prelude to the ulcer, as we would see with the peptic ulceration, where there is actually margins of the ulcer, whether it is very raised or not very raised, but it does have margins. Here you don't see that. Simply drop in the tissue, very clear drop in the tissue resulting from the acid. Now, chronic gastritis. Chronic gastritis is an important entity because it is related to a preventable one, most commonly related to the H. pylori, a very important gram-negative rot that could cause a lot of pain and a lot of complications. If you are in the stomach and you say the word H. pylori, you are going to be right. Why? Because it is related to pretty much everything. It is related to chronic gastritis. Most commonly, it is related to the peptic ulcer, the peptic ulcer in the stomach, or the duodenum. It is related to carcinoma, adenocarcinoma of the stomach, and also is related to lymphoma and also carcinoid tumors. So it is the most common cause of the chronic gastritis. Distant second is going to be the autoimmune gastritis. So autoimmune gastritis is going to be the most common cause of chronic gastritis in those patients who are H. pylori negative. It is less severe but more persistent. Now, what's going to really split what's going to split acute gastritis from chronic gastritis are three important features, very important to remember for your exam. That's going to be mucosal gland atrophy, 1, 2, epithelial metaplasia, and 3, absence of erosions. Very important pathologic features to split the chronic gastritis from acute gastritis. Now, in the long run, those cells are going to become actually first metaplastic, then dysplastic, and that's going to open the door for the development of adenocarcinoma of the stomach, possibly lymphomas, marginal zone lymphomas, possibly also carcinoid tumor. So what are the classification? The first one is going to be autoimmune gastritis, also known as fundic type, usually favoring the fundus, where are the acid producing cells, the parietal and the chief cells are actually, and that's going to be detrimental, as you will see to the presentation of this case. H pylori gastritis, on the other hand, favors actually the antrum of the stomach, resulting in antral type gastritis that may become eventually developing into pangastritis. So chronic autoimmune gastritis. Chronic autoimmune gastritis resulting from autoantibodies that are directed against the parietal cells and against the intrinsic factor. So that itself is going to be actually the reason for this kind of manifestation. Why? Because once they are actually directed against the parietal cells, then they are going to result in destruction of those parietal cells. Usually the autoimmune response is stronger than any other kind of inflammation. In this case, there will be achlorohydria. With achlorohydria, you will see that the gastrin is going to actually kickstart. So as a result of that, you will see that the G cells that produce gastrin in multiple regions in the GI tract are going to become hyperplastic. So much so that they may result actually in the production of carcinoids in the stomach. Okay, so this is where is that related to it from. Now at the same time, you no longer have intrinsic factor, so you no longer are able actually to absorb the vitamin B12 in the ileum, and that's going to result in the development of megaloblastic anemia. Megaloblastic anemia that has actually some neural complications, as you know, and that's going to present in its unique way. So very important to also remember actually the relationship between the megaloblastic anemia and this entity, so much so that we call it, just one second, where is that? Sorry. All right, so this was in the old right. So most often due to pernicious anemia. How about that? So the chronic gastritis is really, if you think about it, it's a conglomerate of symptoms that is presenting as a result of this autoimmune attack against the parietal cells. So it is presenting in a condition called pernicious anemia that includes everything that I mentioned to you: chronic autoimmune gastritis, megaloblastic anemia, achlorohydria, and hypergastrinemia, and increased risk of gastric adenocarcinoma. Right, so this is just going back and mentioning what we have talked about here, the fact that actually the gastrin producing cell, the G cells, will start to become hyperplastic. So first there is G cell hyperplasia that may actually develop into carcinoid eventually. All right, so it may even be, it may go even beyond carcinoid. What is the malignant prelude or a sequel of carcinoid tumors? So as you know, there is, what you call carcinoma in situ, then there is squamous cell carcinoma. And there is, let's say atypical hyperplasia of the breast, and then there is breast adenocarcinoma. How about actually carcinoid? What will follow carcinoid? Neuroendocrine tumors. That's the prelude, for neuroendocrine tumors. All right, so what do you see when you do testing for the autoimmune gastritis? You will see increased level of one of the, of the immunoglobulin. In this case, it is the IgG. In addition to this, you will see low serum levels of B12, which you don't really do, or you do, but you interpret it with a lot of, contempt, so to speak. The reason for this is that the serum B12 levels are very wide. So if you look at the normal value, you will see that it is a very wide value. So you may actually see that the value of the B12 is normal, but the patient does have actually pernicious anemia. And why is that the case? Because the patient will be actually on a decline when it comes to B12 level, but it did not really reach the other end, the lower end of the spectrum of normal. So in this case, the best test to be making actually is going to be the high methyl malonate level, the methyl malonic acid, which is going to be rising. Why? Because the vitamin B12 is a cofactor in one of the reactions that will metabolize the methyl malonic acid. So it's going to rise far earlier, and it will be a clear rise than the vitamin B12 levels. Serology, the antibodies that are directed against the parietal cells, you don't really do, you still do it, but when you interpret it, you have to be very careful in interpretation. Why? Because there are patients who have the antibodies who don't develop the disease, and every time you see that, that's going to take from the value of the test. And then there are those patients who have the disease, but they don't have the antibodies that you looked for. Maybe they have another form of antibodies. So as a result of that, the value of this test becomes diminished, because it will be interpreted, by when it interpreted by the wrong people, it will result in the wrong conclusion. Like all other autoimmune diseases, at least this is how it used to be. Now we're seeing that males and females probably rates are coming to become very equal. So you will see slight female preponderance, and there is also association with other autoimmune diseases. Now the second one is going to be chronic gastritis Helicobacter pylori. Now, this actually gram-negative rod is very important. Why? Because as I mentioned to you, it is preventable, it's treatable, preventable, treatable, and very important because it causes a lot more than just inflammation and pain and possible bleeding, because it will cause everything that you know about actually the pathology of the stomach, from chronic gastritis all the way to peptic ulceration, all the way to adenocarcinoma, marginal zone lymphoma in the stomach. So presents in 90% of patients with chronic gastritis affecting the antrum. So it is antral gastritis. Now in the antrum, as you know, there is those fovular, actually, those fovular cells that produce mucus. And we will see, there is a trick here to understand exactly how the pathology of, the H. pylori, does its magic on the stomach. So there is increased secretion, acid secretion in H. pylori gastritis, which may result in peptic ulcer disease. Now imagine this: it is really affecting, the cells that are present mostly in the antrum, but there is going to be so much, immune response, a very robust immune response, from this pathogen that does not really dig deep within the gastric wall. It stays on the very superficial layers of the gastric walls, or it is simply clinging to the gastric mucosa, to the overlying gastric mucosa. And it does, all this magic through its, many, factors that it has that are going to incite a very, strong immune response. Now, this immune response is going to irritate, the acid producing cells, and that's going to result actually in overproduction or increased production of acid in the stomach. Now the acid production that is happening now, the increased acid production, is going to overwhelm the stomach defenses, but also because it will be going into the duodenum, it will be much easier to overwhelm the duodenal defenses, because it does not have the same protection like the stomach wall. So it will result in a duodenal or actually in a gastric ulceration. A lot of times we see that there are concurrent actually ulceration in both the stomach and the duodenum. All right, so 30 to 50% of the population of the US have the H. pylori. How about that? That's an incredible actually number, if you ask me. And this is in a country where the public health services will take care of things fair and square in case there is contamination of the food, but still up to 50%. In other countries, maybe up to 80, 90%. It is a fecal oral route, so where you get it from, usually restaurants. And it's common in, I don't know if you can say that, in areas of poor sanitation, because now it is everywhere. All right, so how does it do its magic? As I mentioned to you, it is a gram-negative, curved rod, and produces urease. This urease is going to, provide a cloak, CLOAK. You know what a cloak is, right? Cloak, a shade, if you will, a shell around the pathogen, where it's going to be, where it's going to have ammonia that is going to save it from the acid that is nearby. Also, it has flagella. This flagella, helps it to actually to move from one area of high acid concentration to another area that does not have that much acid concentration within the stomach, lumen. It colonizes, as I mentioned to you, the mucous layer lining, so it is really a very superficial, pathogen, and it does not really dig deep within the gastric wall, usually to the most superficial areas of the gastric wall. I mentioned to you the flagella, the urease, which generate ammonia after it converts the protein, and that protects it from the acidic environment. And then there is the adhesion, and finally is the toxins such as the CAG-A, the cytotoxin associated gene A. This actually cytotoxin is going to result in the creation of a very strong inflammatory response in the gastric wall. So the balance between the protection and injury will tilt in favor of injury. Why? Because you do have increased acid production, and you have actually now this inflammatory response. The inflammatory cells itself will start to wreak havoc on the gastric wall. Besides the acid, that's going to result in more acid getting through, resulting in ulceration and resulting in inflammation in this case. So much so that it may result over a long term in the production of peptic ulcer. So antral gastritis with continuous infection and no treatment, someone who did not receive the treatment or received incomplete treatment or received treatment that to a bug that became resistant, as we know that now, that's going to result in multifocal atrophic gastritis, intestinal metaplasia, and in the long run, gastric carcinoma and lymphoma. So what is the pathogenesis? This is a very important slide actually to keep in mind when it comes to the pathogenicity of the H. pylori in the gastric wall. The first one is going to be the hyperacidity that we have just talked about. The second one is going to be the pro-inflammatory cytokines that will do the magic for this pathogen without really having, to have the pathogen within the gastric wall. And thirdly is going to be the thrombotic occlusion of vessels that are going to result in loss of tissue, ulceration, and also losing this very robust vascular network that will reroute the acid somewhere else into the stomach. You can see here actually that these pathogens are very superficial. They are, if they dig, they are within the most upper layer of the epithelium. They look like, what do they look like? For those of you who live near the sea, with this comma shaped, seagulls, right? Seagulls. So they look like seagulls. At the same time, you can see the amount of inflammation that is being, that is happening in the lamina propria. There is a lot of inflammatory cells. Look at these inflammatory cells here with this peripherally located nucleus. In addition to this, you see the sunrise, the sunrise appearance, right? The area of clearance above the nucleus. What do you call this area? What is this cell actually? What is this cell? Plasma cells, right? Plasma cells have peripherally located nucleus, and they have a clearance, above the nuclei. That's called HOF, right? The HOF area. And you see those actually immune cells. These plasma cells are, full with these, very red, pinkish globules. So these pinkish globules are actually immunoglobulin. This is what plasma cells do. They produce immunoglobulins. So those actually, the plasma cells that have these immunoglobulins are called Russell bodies. Russell bodies, remember that. So you can see even without it digging within the pathogen, there's a lot of actually inflammation that is resulting from the presence of this bacteria on the most upper layer of the gastric wall. There's so much inflammation that actually when you open the stomach, and usually you open the stomach along the greater curvature of the stomach. So you open it along the greater curvature and then you spread it out. What does it look like when it is normal? It looks like, butterfly. It looks like a butterfly. Now it does not look like a butterfly anymore. It looks like a triangle to you, right? And the reason for this is that there is a loss of tissue, a loss of lots of tissue as a result of the ongoing inflammation. And this, darkish color here is resulting from the presence of the chronic inflammation that is happening in the gastric wall. Now compare this, this gastric wall, this normal gastric wall, with this very thick mucosa right here. This is a muscularis mucosa right here. So very thick mucosa. Compare it to this one right here. It's much shorter. So much tissue has gone, right? So there is a lot of loss of tissue. In addition to this, you see, on from this power, you see a lot of dark color. The dark color are all inflammatory cells, usually lymphocytes. So much so, there is so much chronic inflammation that those actually inflammatory cells will start to organize to create, what looks like pseudofollicles. Okay, pseudofollicles within the gastric mucosa. This is the ground zero, where actually you may see the development of marginal B-zone lymphoma, because those inflammatory cells first are going to be polyclonal, but with repeated infection and repeated inflammation that is happening in the gastric wall, they may actually turn monoclonal, as a result of the increased, rate of the cell cycle, the turnover, rate of cells because of the ongoing inflammation. Some of them may actually go monoclonal, and that's going to result in, the creation of a very distinct, feature of the marginal B-zone lymphoma that is known as the lymphoepithelial lesion. And what is meant by that is simply that the inflammatory cells will find its way into, the gastric glands, destroying the gastric glands. So in a way, actually, it is the ground zero for the development of the marginal B zone lymphoma. Okay, so in this, this pictures here showing you, the first one is, a silver stain. Usually you do silver stain for a lot of fungal, elements, and for a lot, and in this case for this pathogen, because it does pick up the silver stain very aptly. And you can see it here, it is loaded, in the most upper layer of the mucosa. And then here you see that, the neutrophils, at least in the early stage of the inflammation, are going through the crypts of these gastric glands. And they are going to start to aggregate within the crypts, as you can see here. Look here. So resulting in what's known as a crypt abscess. You may start to see crypt abscess right here. So as I mentioned to you, whenever you see a neutrophil in the gastric, in the intestine, and all the way in the GI tract, actually, every time you see a neutrophil above, the basement membrane, as you can see it here, or in the lamina propria, and it's in direct continuity with, nearby, epithelial cells, that it is, abnormal, and you need to look for the cause. Now, in addition to this, you start to see also the pseudofollicles that I mentioned to you, and their interaction, their, a relationship with the nearby, gastric glands. At one point in time, these actually cells, these lymphocytes, will become malignant, and they will be invading those glands. That's actually what you call the lymphoepithelial lesion, and that's going to be the ground zero for the development of marginal B-zone lymphoma. Now, if it does not go this route, there is another route that it may take, which is intestinal metaplasia. So you start to see, the instead of the gastric pit, you start to see intestinal metaplasia, and you start to see also goblet cell metaplasia, that if it goes unabated, untreated, and uncorrected, it may develop into adenocarcinoma of the gastric wall of the stomach. What are the tests that are used to identify H. pylori? There is the urea breath test, and that actually depends on the production of ammonia. Unfortunately, there are other pathogens that may also, produce ammonia. So it's not really that specific, but it is pretty good, at above 90%. Just keep in mind that it is not the only one that will actually come up with a positive urea breath test. The other one is stool antigen test. It's also, excellent for screening and cheaper than the urea breath test. So 2 points, for the stool antigen test. Positive when there is an active infection, and negative when the infection has been eradicated. So you can also use it to follow the course of the disease. Again, the sensitivity and the specificity are above 90%. Now, the gold standard for this is going to be actually a gastric biopsy, but unfortunately it is invasive. That's going to be followed, gastric biopsy that will be followed by histomorphology, 1, 2, PCR, polymerase chain reaction, or actually culture, which is going to be also very important. So three tests that will be, that are going to be the gold standard, albeit an invasive test. All right, so serologic tests I have been discontinued, but they still do it, believe it or not, and they don't do it for diagnosis, but they do it just for the sake of completion. As I mentioned to you, you may do any test you want as long as actually you know how to interpret it. If the results come back negative, you know, and you know that there are patients who don't really have. So if the test came back negative, you should not say that the patient does not have the disease, because the patient may have the disease but with an absent parietal autoantibodies. This is a nice table from, I believe, Robbins, that's going to be really summarizing pretty much everything that was said here. So it's nice to actually take a look at it and see, especially the sequela, and the serology that you see in chronic gastritis. Now, peptic ulcer disease. Again, if you say H. pylori, you're going to be right. It's going to be very detrimental for the development of peptic ulcers in either the stomach or the duodenum, or in both. So where are the common sites for this? In order of decreasing frequency, it is the duodenum has the first portion of the duodenum, the most common, then the smaller actually curvature of the stomach, the gastroesophageal junction, and also within the margin of gastrojejunostomy, Zollinger-Ellison syndrome, where you see a lot of gastrinomas that will result in increased level of, of acid that will result in multiple ulceration within the GI, not just the stomach. And finally, if there is an ectopic gastric mucosa of Meckel's diverticulum, because in this case the diverticulum will not have the defense mechanism that are given, that are allowed for the stomach, and as a result of that, this acid will result in inflammation, will result in perforation and acute abdomen, especially in children. Here's an example of, again, of the silver stain, picking up all these, all of this black are actually H. pylori pathogens. Now this is, an ulcer in the first part of the duodenum. You can see that it is a very well circumscribed and pretty small ulcer. This one here is on the smaller curvature of the stomach, slightly, I would say, suspicious. Why? Because it does have what you call heaped up margin. Heaped up margin, so it's not really like on even plane with the rest of the stomach wall. Here's an example of a gastric ulcer that has perforated, resulting in the release of air, and you can see the air on beneath the diaphragm leaflets. What do you have? Oh, you have, great, wonderful. Thank you very much. Wow, well, it's too late for that. We're done. Thank you very much. All right, so let's continue first here. Again, I put the slide again to get you the message that this is an important thing to keep in mind. Another one also to keep it in mind. So H. pylori implicated in gastritis, chronic gastritis, peptic ulceration, gastric cancer, and lymphomas. All right, so what do you see? What are the features of actually a benign ulcer? Usually the size is important, less than 4 centimeter maximum diameter, and then you need to see a very clear margin. You don't see a lesion that actually extends into the nearby tissue. Sharply demarcated margin. Most gastric ulcers are benign. Now, why is that important to mention here? Because in the folklore of medicine in the past, we used to think that all actually of gastric ulcers are malignant. Now we know that this is no longer the case. Actually, we know that only a small minority of gastric ulcers are actually malignant. Okay, maybe like in some series it's probably between 4 and 10%. At one point in time, we thought it is in the 80, in 80% and above. So that's not really the case. It is a small number of cases, about 4 to 10%. Now, not to actually mix that with a gastric carcinoma that ulcerate. This is really where the mix came from. the fact that there are some gastric carcinomas that are, ulcerating, that present with an ulcer, and you count it as actually a gastric ulcer. That's not the same. Okay, just to keep in mind. So, ulcers pretty much in the stomach or in the duodenum, even more in the duodenum, are benign entities. Very rarely or are they malignant. So a small percentage of gastric ulcer may be malignant, reason for biopsy, whereas duodenal ulcers, it's almost never malignant, so reason for no biopsy. All right, so gastric ulcer, again, we're talking about the benign ulcers, usually on the lesser curvature. Up to 50% of those with gastric peptic ulcer have also concurrent duodenal ulcer. And what is the culprit here? The acid, right? And usually you can relate it back again to the H. pylori. So features I mentioned to you all, so less than 4 centimeter in diameter, round to oval, very punched out area with a clean base. The reason for this, the clean base is because the acid has actually digested all the debris that resulted from the ulceration. Whereas in a malignant ulcer, you will start to see that the pit does have actually, cellular debris. So important point to be made. So because of the acid, the high acidity that you see with benign, gastric ulcers, you will see that the pit is clean. But in gastric cancers, gastric cancers that ulcerated, that are ulcerating, as a result of the invasion, there will be a lot of tissue debris that are present in that, in that pit. So the margins now, when you turn it on the side, if you take a cross section of that ulcer and you look at it from the side, in a benign ulcer, you will see that the margins are on even plane with the rest of the stomach. In a cancer, you will see what you call heaped up margins, which should raise the suspicion of gastric carcinoma. Then the rugal folds, the famous rugal folds of the stomach, radiate from the ulcer in a spook-like fashion, what looks like a wheel kind of fashion, like sun rays, if you will, fashion, but not the case with gastric carcinomas. So this is what we have talked about. So you can see actually the wheel-like fashion, right? The sun rays, this is the sun, and these are the rays coming from it. The size also is not larger than 4 centimeter, very punched out lesion, clear-cut borders, and you have to take my word for it. When you cut it and you look from the side, it's on even plane with the rest of the, the mucosa. So all of these are actually features of benign gastric ulcer. Here is, to differentiate between the gastric and duodenal ulcer. You can go through it. I did not want to go through it because it is usually the, medicine, part that will be given to you hopefully today by Dr. Suhaibani. But I wanted to mention to you that, there is one test that is very important, and that is actually the BAO, the basic acid output, and the maximal acid output, to differentiate between the two. We used to look at, how food affects the two conditions. Still a lot of clinicians use it, but it's not really, it's not really holding true, and it's not really mentioned in a lot of, textbooks. So it does mention, for example, here that the epigastric pain exacerbated by eating, whereas, for a duodenal ulcer, the epigastric pain is relieved by eating. But again, it's not really that strong of a criteria that you can use to differentiate between the two. Intractable pain, that is going to be the first actually complication of peptic ulcer disease. It is not the most common, but it is the one of the important presentation of peptic ulcer disease. And as I mentioned to you, its relationship to food, if it's relieved or if it's exacerbated, that's gonna help you slightly to differentiate between duodenal versus gastric. Bleeding is actually the most frequent complication, happening in 15 to 20%, and 1/3 of the patients, almost 1/3, about 30%, 25 to 30% of the causes of death, in patients of gastric ulcer. So the bleeding may be so profuse that it may result in death of the patient. It may be the first manifestation. That usually happen when the ulcer erodes into a major vessel, such as on the posterior wall of the stomach or anywhere else, that will result in massive hemorrhage. Perforation, penetration, and peritonitis, if it goes through the full wall, resulting in actually moving the contents of the stomach into the peritoneum, resulting in peritonitis in about 5% of patients and accounts for 2/3 of ulcer deaths. So luckily it is less common than bleeding. And finally, obstruction, especially when it is at the level of the pylorus, it may present with obstruction. All right, so this is the first lecture